Good afternoon, and welcome to Insight Memory Care Center Care Partner Training. Our mission is to provide specialized care, support, and education for individuals in all stages of memory or cognitive impairment, their care partners, and the community. Our vision is a community where those living with memory or cognitive impairment and their care partners can achieve the highest quality of life. This is geared towards family and caregivers caring for loved ones at home. It's free and open to the public, and learn more about our organization and our upcoming classes and events at insightmcc.org. Today's topic is it Lewy? Information and support from the Lewy Body Dementia Association. Now I'd like to introduce Brandi Hackett, licensed mental health social worker. She attained her BA from Shorter College and her MSW from the University of Georgia. Since graduating in 2004, Brandi has worked in a variety of settings, primarily with older adults. She began her role with the Lewy Body Dementia Association as manager of support services in September 2020, where she supports individuals, care partners, and the LBDA volunteers. She has published for her article on compassion fatigue in the Journal for Certified Senior Advisors and has presented multiple CE classes for allied health professionals. Welcome, Brandi. And she will be speaking while she's talking. If you think of any questions, please put them in the Q&A, and I will be able to present those to her at the end to get your questions answered.
Hello, everyone, and welcome to today's presentation. Thank you, Melissa, for a great intro, and I'm very happy to be here with you guys. We're going to take the next few minutes describing what I'm sharing with you guys on the slides, and this will be recorded, so you're welcome to go back and watch the slides again. You can also follow up with some of the resources that I mentioned at the end for additional information. As part of our presentations, we do not share the slide deck in its entirety, but again, this is being recorded. This is truly for educational purposes and should not in any way be considered medical advice, as this should be care received directly from your medical professionals. It should also not be taken as either legal or financial advice. We as an organization are committed to diversity, equity, and inclusion in research, access, in care, and also in support. So on our first slide here, I'm sharing what is a Lewy body. And this is an accumulation in the brain of a certain protein. At this point, they think is primarily alpha-synuclein. And it binds together and builds upon itself and creates a Lewy body in the brain. And this is the change in the brain that causes all the symptoms that we will talk about today. This is an incredibly misdiagnosed form of dementia, and we'll talk a little bit about that later. Right now, current statistics are that around 1.4 million Americans are affected. This is typically adults over the age of 50. However, we have cared for individuals in their 30s and have cared for individuals well over 100. And so there is a large age band of those that can be affected by Lewy, as well as those who are caring for those with Lewy. It is the second most common cause, and again, the key word here is a progressive dementia after Alzheimer's disease. It is a progressive brain disorder that was originally found by a Dr. Lewy, is where it has its name, who was a neurologist, and he found these abnormal protein deposits in the brain that we now call Lewy bodies. There are two conditions that are under the umbrella of what's considered Lewy body dementia, and this can often be differentiated by something they call the 1-year rule. There's some dispute around this because there's a lot of gray area as well with this, but Lewy body dementia is primarily seen as encompassing these two conditions. One is called Parkinson's disease dementia, which you may hear it called PDD. And this is when a person has an established Parkinson's diagnosis first, and then typically a year or more later begins to develop dementia, which is the changes to their memory and thinking that are different from their prior baseline. The other condition is called dementia with Lewy bodies, sometimes referred to as DLB. And this is when those changes to memory and thinking happen first. Now, the person may have some changes called Parkinsonianisms that are happening as well, but it isn't clinical Parkinson's at that time. So this data is about a little over 10 years old now by Dr. Galvin, but we are still seeing this very, very frequently as individuals are experiencing these symptoms and families are supporting them. Many, many times with a diagnosis, it can require multiple physicians. And this may be starting with things like a primary care doctor. It might be because of a hospitalization that a hospitalist or a hospital physician will say, hey, this looks like, or this could be. But typically it is from a neurologist, which is the specialist. And for some, there is a specialized neurologist, which is called a movement disorder specialist. In this unique specialty of neurology, there is an online directory that is available, a movement disorder specialist directory that can be another source in helping to find these professionals. But again, most of the diagnoses were clarified through a neurologist and supported by a variety of scans, tests, questions, etc. And often they are trying to exclude many causes as well as include many causes. And so it can take some time to receive a diagnosis. And in many cases, we find that it can take over a year to receive a clarified diagnosis. Many, many times there is another diagnosis first prior to it being a clarified diagnosis of a Lewy body dementia. Sometimes we see this can shift depending on the age of the person that's experiencing symptoms. So often as I'm supporting individuals on a helpline and they're in their 40s and 50s, they're coming to us and saying, well, it was first diagnosed as schizoaffective disorder or bipolar depression, work stress. If we have someone in their 70s and 80s, may be the opposite of that. Well, they'll say, oh, it was just described as part of aging. It was described as a dementia, but it wasn't specified. And so there can be other things like a Parkinson's diagnosis first, and then as things develop, they'll go, you know, we really do think that this is more, again, DLB, dementia with Lewy bodies, with the Parkinsonianisms. And so there can be just continued clarification. And sometimes there can be a start of just mild cognitive impairment or MCI. And so they notice there are changes, but the doctors are trying to figure out the why. And figuring out the why of over 70 plus different causes of dementia can be a complex process. And as we talk about the symptoms, you'll notice that many of the symptoms that people experience are experienced by a host of other conditions and sometimes non-related neurological conditions. So it might be cardiac conditions. So they may be seeing a lot of ologists, but not having all that information pulled together with one potential cause. There can be a lot of barriers to diagnosis, and sometimes this is what is reported to the doctor. So it might be that symptoms are showing up in a variety of ways. It might be, as I sometimes describe, sometimes the symptoms feel like they're on a bit of a dimmer switch. So I've had individuals and I've had their families say, you know, for a couple of days I was feeling X, but I only felt that for a little bit. And so maybe that was something else. Maybe that was because I had X, or this else thing was going on, or I was stressed because of X, Y, and Z. Sometimes things aren't reported. So I'll give you an example of that. I had a daughter that I was speaking to who was supporting her father, and her father was actively hallucinating and having altered perceptions, but his involved primarily a dog running outside. So for him in this instance, he saw what would be a normal potential occurrence of a dog running outside. So he would look out the window and see the dog. Well, it took a while to notice that no one else could see the dog that he was experiencing. And so, of course, that wouldn't be reported as a symptom to the physician because he didn't realize it was a symptom at all. He thought it was just something he was perceiving that other people could perceive. Sometimes it can be what would maybe considered taboo or potentially embarrassing symptoms. So this may be related to things like incontinence needs that came out of nowhere, or constipation that may be a part of this. They may have had a fall that they didn't want to share with others. So sometimes it's a person's insight of saying, these are changes that I'm feeling. And sometimes the care partners may or may not be there to say, these are changes that he's feeling or she's feeling. And so sometimes what's presented can be different. And we'll talk a little bit today about some tools that can help with these conversations. On the other side of that coin, there may be clinicians or physicians that aren't aware. So you may be supported by a physician that may not be as aware, or may have never treated someone with Lewy, for example. And because this is such I call them symptoms in buckets, so they can show up, and we'll talk about some of the symptoms in a little bit. Sometimes you, again, get sent to all the ologist, but maybe not the neurologist, or maybe there isn't a referral at all, or the person has inability or resistance because of transportation issues to an appointment, or possibly there may be parts of the testing that they are unwilling to participate in or cannot tolerate for one reason or another. And on top of that, they may be saying, we know that there's issues, but things aren't developed to a point at this point where we're able to really notice the underlying cause. And so there's a lot of this, what I think of hurry up and wait, where, we're relying on the physicians to be aware of Lewy, but we also are responsible in providing them enough information to be able to help in clarifying the diagnosis. As of today, there is no widely available biological test to say, check Lewy. There's been a couple things to help in clarifying the diagnosis, such as a DAT scan and other types of scans and tests that can help to supplement the information that's being considered for diagnosis. There's a couple things, lumbar puncture, skin sebum tests, that are currently primarily in research, less so than in the clinical setting at current, but some really exciting things to hopefully continue to clarify the why behind the symptoms people are experiencing. So this can be an extremely different dementia than Alzheimer's. And so this can be tricky, because if a person is involved in memory care or being supported by someone, whether it be a family member, a friend, a pastor at church, etc., they may be really familiar with the word dementia, but often when a person is familiar with the word dementia, they're familiar with Alzheimer's dementia. And this makes sense because Alzheimer's is the most common form of dementia. And so Alzheimer's, we're looking at often changes to memory. So if I were to take a microphone and go out on the street and say, what is dementia? A lot of people would respond and say it's when a person can't remember anything or has trouble remembering things. And often, just in the same way we would say Parkinson's, a lot of people automatically think tremors. When a person says dementia, often is thinking about the symptoms of Alzheimer's. And so in Alzheimer's, again, we are looking at changes to memory and thinking. We are looking at how information is stored, how they are forming new memories. We are looking at often a gradual and sometimes steady decline in their ability to think and remember over time. And the physical symptoms that can come from this often come much later in the disease process, unless there's other underlying conditions going on. But with Lewy, we're looking at a whole different set of symptoms. And I know that this is very small print on the slide, but this is an available resource on our website and is part of the resources I shared with Melissa to share with you guys. So these are more of the symptoms that we see with Lewy. So we talked about those cognitive symptoms. So there can be some memory and forgetfulness, but what we see more often are those changes in thinking. So things that were once easy. And that may be things that they're doing in their job or their work. It might be in instances where they're needed to multitask. It might be issues in terms of their maintaining attention or attention span. I have one gentleman in our Living with Lewy group that said it just feels like a mega dose of ADHD. just a really difficult time maintaining attention. Sometimes this will come out in the way that we speak to others or the way that we receive speech from others. And sometimes that's called disorganized speech. There may be moments where it's fluctuation. So there's just these episodes where the person is just less able with their memory and thinking. There can also be some difficulties in what sense of direction or spatial relationships. So if I were to take my cup, and I know with my cup, I need to hit, the table if I want to put it down, unless I want to clean up a mess. And so for here, my brain has to be able to calculate distance between my hand and the table where I'm going to sit my cup. If I go too close, I might hit my funny bone, as we call it. I might cause injury to my arm or my elbow. If I'm going too far, I'm going to have a mess on the floor. And so the brain's job is to help in those spatial relationships to determine where our body is in space and also extensions of our body in space. And so sometimes I think about things like driving. So a body we have to think when we're wrapped in a car, we're sitting in a car and we're responsible for driving, that can often be seen as an extension of our body. So the same way that our brain is judging our proximity to a wall, or our proximity for our cup to be placed correctly on the table, as we're sitting in things like a car, it can affect how we're judging proximity to a mailbox or to that pedestrian or the curb. So this change in terms of spatial relationships can have a true effect. We talked a little bit about the Parkinson's connection or the Parkinsonian connection. And so we can see those symptoms because these brain changes cause those changes in the person. So they may have rigidity. You might find that when they're walking, they're not picking up their feet like they once were. And sometimes that's called shuffling because you can sort of hear the shh, shh, shh on the floor with the shuffling. Tremor that we mentioned, for some, they experience tremor. They may just notice that they're having a harder time getting up or that it's taking longer to get from point A to point B. If anything, we hear a lot about balance problems and we hear about falls. And as we can imagine, this can be a really complicating factor because a fall with a head injury can often make many other things worse. Also, there can be a change in facial expression. And so often we use our face to really express how we feel. And what has been described as sometimes a blunted or a flattening of the facial expression. So they're just not as able to show through their face what they're feeling. And if we can imagine, we're used to, if you experience joy, you look a certain way in the face. If you experience anger, you look a certain way in the face. And often that can be a source of miscommunication if a person is unable to show some of their feelings in ways that they once did. You might also notice a change in smell or the ability to smell. And this was, of course, complicated by things like COVID, where people also had changes or inabilities to smell. You'll also notice there may be a change in posture. And so for this, it's sort of how we sit and how we maintain without leaning certain ways when we're sitting and standing. There can also be changes to what's called behavior or mood. And this is often in what's called altered perceptions, which can include hallucinations as well as delusions. This is frequently why we're getting calls through our helpline, as a person is experiencing things in their environment through any of their senses, but we hear mostly about visually, of things that other people are not experiencing. So this may be a very detailed something that they're experiencing, or it may be sort of a vague experience. So they may say something like, I know that is my printer, but my brain is telling me it's a turtle. Or I had one lady that was lying in bed and said, the man standing over me lecturing all night, and it was her coat rack full of coats that the daughter had placed at the head of her bed because she was frequently cold and she needed to be able to easily access those coats. And so if you think about lying in bed and it's dark and you're looking up, it's pretty easy to see how the brain could misperceive something like a coat rack standing over you as a human figure. So sometimes there are those illusions or misperceptions of things that are physically there that are seen by the brain to be something else. And sometimes these hallucinations are bizarre. So we hear a lot about little tiny people or figures. We hear a lot about children. Hear a lot about animals. And so people are experiencing, and sometimes the descriptions are things like a chair with a lampshade head and human hands. And so sometimes it can be quite bizarre. For some, these can be frightening, but we do hear most of the time that they're not. Now, a person may feel a host of other emotions because of what they're sensing, but it may not be that they're scared. So they might be annoyed. So if you walked in and you saw a bunch of rowdy children sitting around your table, you may feel or act a certain way. And so often they are responding appropriately, and I have to be super careful in saying that, responding appropriately to what their brain is telling them is true. So the same way that you and I would, if our brain said this is happening, we would have a certain emotional response, sometimes a physical response to the things that are happening that we're perceiving. And so another form of this is called a delusion, and it's when we get something stuck in our brain. So it's a fixed false belief, and a lot of these may include things like paranoia, accusations of infidelity, something called phantom boarder, where we are perceiving people in the home that do not belong in the home, that aren't living there, that aren't staying there. Capgrass or capgras is another form of this, where we see a person, and even though that person may be our person, our loved one, our family member, our brain tells us that that person is not that person, or is an alternate version of that person. And so it can be difficult because, again, we're responding to what our brain is telling us is true. So if I'm looking at Melissa, for example, and I say, "Where's Melissa?" And she's like, "I am Melissa." No, you're not. Where's Melissa? And often that can escalate to, "You've done something with Melissa. I need to get Melissa." We've had issues where there's been some violence, unfortunately, and other reactions, because, again, if a person's brain is telling them that their person isn't there, they've been replaced, or that they're cheating, or all these other things, often, again, they're reacting to those things as if they are true. And so there can be techniques and there can be medications at times that can be helpful with these, especially if they're causing distress. And a lot of those will be shared as resources after the presentation. We also can see changes in mood, and that may be increased depression or anxiety. It may also be an increase in something called apathy, which is our internal motivations to do. So things that may have brought us joy before just doesn't. We just can't motivate. And so those can be difficult moments because it can be perceived as lazy or disinterested. And it may be just this shift in motivation. We do have a great short video called a Lewy brief on apathy that was just created. And that's something else that if this is something that you're supporting, may be helpful as a resource if you'd like to connect with us for that video. We can also have, here's some of the other buckets that we've talked about. There can also be issues with sleep. And so for some, they will experience a condition, and this can happen sometimes decades before. And it is called REM sleep behavior disorder. And so the person is acting out their dreams. So in a time of sleep, when our body is normally paralyzed or really still, and why it's called rapid eye movement is sometimes our eyes are what you can see moving. That mechanism sort of clicks off. And so in those situations, they are acting what their brain is processing in those moments. And so they are sleeping, but they might be flailing or screaming or getting out of bed or falling out of bed. They may hit a hand or an arm or a leg on something to the side of the bed. They may have no memory of what's going on in those moments and may wake up with a cut on their hand and just unsure. Or they may wake up, unfortunately, where a bed partner sharing a bed with them is injured because of these reactions to this condition. There can also be insomnia, where a person has difficulty going to sleep or staying asleep. And sometimes this is complicated as well by other conditions. So I had a gentleman that had an enlarged prostate. And so he was up and down all night with urination. And so sometimes it's not in a vacuum that a person is experiencing these, but can be complicated by other conditions as well. Some also will experience restless leg syndrome, which is just an ability or a desire for us to move our legs, especially a lot of people will report this in the evenings where it's just like, I have to move my legs. There's just an anxiety around movement and as well as excessive daytime sleepiness. And again, I think about a lot of these symptoms almost on like dimmer switches. So even though a person may have the same diagnosis, how they're experiencing these symptoms, not only themselves in general, but sometimes day to day, moment to moment, hour and hour, can be a bit like a dimmer switch. Autonomic, this is the list where I can tell you that many people aren't relating it immediately to a neurological condition or especially to Lewy. Sometimes a lot of these things are related to things in other conditions or sometimes just aging alone. So sexual dysfunction, urinary incontinence, constipations, loss of consciousness, shifts in blood pressure, temperature control. And so somebody may say, well, they've always had a blood pressure issue or they're being treated for a cardiac issue. Sensitivity to heat and cold. Oh, well, she's always cold. She's always needed a blanket around. And so our symptom checklist at the end also has other things and how to make some notes for the doctor's appointments and how to report this to the doctor. So speaking of getting organized for doctor's visits, and I did share this link at the top as part of the resources that Melissa will share after this. But again, it's really important for families and individuals to do their best to try to clarify symptoms. And because we have a limited amount of time with physicians as we are meeting with them, and sometimes long spans between those visits, we want to make sure to make the most of those visits when we are present. So we want to talk about the symptoms, but as a social worker, we use an abbreviation called AEB, as evidenced by. So not just he's had changes in his thinking, or she's thinking differently, or she's not able, but how does this show up? How does it affect quality of life? What does it look like to that person? Are there things that are constant? Are there times of day when they're worsened? Is there anything that you do to make it better? So if there's increased anxiety and every morning after your walk, you feel better, or you're able to talk to a loved one and you feel better. Is there certain things in terms of apathy or motivation that inspire or want, sort of lead you to different results or behaviors? How are they affecting daily activities? So are there modifications that can be made? And sometimes there can be professionals that are brought in to help get really creative. So we've had individuals that have been lifelong woodworkers and artists and readers and writers. And so sometimes if we're having issues with double vision or visuospatial and attention span, or if a person loved to cook, we had a person that adored cooking, baking specifically, and anyone, if they've ever baked, they're familiar with its chemistry. So you miss an ingredient, you put in too much of an ingredient, it can really not work. And so this particular person really wanted to continue baking. And so they worked with an occupational therapist to modify the process of this. So there were certain checks and balances that were put into place. They used simple tools like note cards to cover up everything but the step that they were doing in those moments to cook. So they weren't distracted or they wouldn't lose their place on a recipe. And so there was modifications to try to help in those daily activities, not only maintain purpose, but maintain pieces of identity that matter in terms of how we spend our moments and our days. There are some great checklists online, and this is just one that I found on this website, so I wanted to share it. But medications, I can't tell you how many times that this can come up. And so not only is it, what meds are you currently on? And as I tell families, meds are really anything we put in our body. So this could be a suppository, a cream, a nighttime tea, different holistic meds, CBDs and THCs and all the things, along with medications that are found over the counter, along with medications that are given by a physician. And so having this organized when it was started can be really, really helpful in if we're having side effects. Is there a correlation between when something was started and when things were better or when things worsened, or didn't change at all? So there may need to be adjustments to certain things. I think it's also really important to know when medications are taken in the day and making sure that we're sharing that. So for example, I had a lady that I took care of years ago that was having some pain control issues. And so she explained to the doctor, she said, the meds aren't working for my pain. And the doctor said, well, when are you taking them? And she said, well, at breakfast and lunch. Okay, well, most people would assume that the times of breakfast and lunch are stable person to person. Well, in her situation, she was a night owl. So she did not have breakfast until noon. She did not have lunch until closer to what people would consider dinner. In the South here, we sometimes call it supper. And then, so everything was off more than she thought. And it ended up, she was actually going about 12 hours without treatment. And so instead of giving more medication, when in this instance makes sense, if the meds weren't helping, maybe more would help more. What they did is they made adjustments. And so they said, is there a time in the morning when you get up to use the restroom? And so they started making adjustments to when certain treatments were given, and her symptoms were actually better managed. And so instead of having to increase a certain med, which could have a more likely concern in terms of side effects, they were able to modify the scheduling of the med. So we always want to make sure that those conversations are very transparent. And especially that different doctors are chatting, that you get an accurate count. If there's a hospitalization, that we know what changed, when it changed, et cetera. But medication list and how we're treating symptoms is one of the most vitally important parts of these conversations with physicians, and also about feeling better and having better symptom management and quality of life. Other things that I think are extremely helpful, and these aren't things that come up often, but to me, the supports around you, how you're fueling your body with food, how are you sleeping, and could that be improved or not? How are your days? What activities are you trying to maintain or enjoy? And then what other substances may you use, such as smoking, drinking, et cetera, because sometimes those can complicate other treatments or other solutions. It's important to be open and honest, even if there are quote unquote taboo or more embarrassing symptoms, because those could be parts of not only clarifying this diagnosis, so constipation, for example, but it can be helpful in terms of making sure that a person can feel as well as they can for as long as they can. It can also be important to talk to the doctor about any major changes. I have one family that I supported where there was a sharp increase in symptoms of depression and sadness. And the doctor couldn't figure it out. They had started a new med, it was doing really well, and all of a sudden it wasn't. And finally, it was shared with the doctor that the person had just had a loss of a pet. And so they were there having a lot of support out of this pet, and the pet that they had had for over a decade died. And so once that was shared with the doctor, then the solutions and the supports were modified to make sure that that was addressed as well. And that grief was supported, and then other adjustments could be made. There's also other things about the wellness self-assessment. And this was another resource link that was shared with me by our occupational therapist and director of education, Julia. But it is a wonderful set of worksheets. And again, I am sharing this link so that you can take a look at these worksheets to see what may be helpful in these conversations too. But they're from the Davis-Finney Foundation, and they talk about wellness. So what areas of concern are there, and what actions either have you taken or should you take to help with those sections of independence? This can be challenging for those that are wanting to support the person that they love, and for the person that is experiencing these changes as well. And so there can be these symptoms that we've talked about that are much more than just changes to their memory and thinking. So there can be things like issues with getting around or increased falls, the blood pressure issues and things like syncope that could cause increased falls, the sleeping problems. And again, if you share a bed, if one person isn't sleeping, it's likely that it's affecting the sleep of the other person. And sometimes changes in alertness or daytime sleepiness may interrupt schedules. Often because a lot of these symptoms are on the dimmer switch that we talked about, the fluctuations in this, the up and down of ability and lessened ability can be complicated because you may have something on a calendar that it might need to be generally earlier in the day because you know that is typically a better moment for that individual. Or you can say, sleeping in is one of the best things for us because we're not sleeping well at this point. And so we get our best sleep really in that 7 to 10 a.m. range. And so looking at ways to bump support or bump appointments to a later time in the day might be helpful. The behavioral symptoms or altered perceptions can also be complicated. So if a person is not only seeing, hearing, tasting, smelling, touching, things that other people aren't through these altered perceptions, and then the body is naturally reacting to this brain truth, it can be really tough not only to feel, because it's hard to judge what reality if reality has such shifts, but it can also be really difficult to support. And again, there's a couple videos that we'll share about some of the support techniques that are there. Also, a person's activities of daily living, their ability to provide independent care for self, dressing, bathing, grooming, brushing the teeth, combing the hair, walking, ways that we get around in our life may be affected sooner because of the association with Parkinsonianisms and Parkinson's, where a person may have lessened ability earlier than some of the other dementias. And so also there can be changes because of some of the autonomic changes that can happen, such as changes to blood pressure regulation. But we really want to focus as much as possible on living well. And so I organized a couple thoughts that we share with those that connect with us, but also I think are just really good reminders. People ask a lot about research in this area, and there's some absolutely wonderful research going on through our research centers of excellence and other entities. But one thing that I hear and I read over and over and over in the research with dementia, as well as Parkinson's, as well as Lewy, is the importance as much as possible of movement throughout the day. So finding even tiny ways to add movement as much as possible in the most safe ways. And again, sometimes this can take a consultation with a physical therapist, a physician, et cetera, to make sure that you are doing what is considered safe in those moments. I think it's also important to be proactive. And this can be tough when it can feel a bit like a moving target. But knowing that, what are those safety nets that are available? I just had written an article last year about what I call thresholds and safety nets as a social worker. So we all have thresholds of care that we can either handle emotionally, handle physically. So for example, if I have a caregiver that is 5'4" and a person needing care that is 6'4", there's probably going to be a point in that care, if care develops and is needed more, well, the person that is 5'4" may have increased difficulties or need more support in providing care for the person that is much larger than they are. There may also be preferences, and this can vary sort of situation to situation. So one of the examples I give is a personal preference. So my father has a different type of dementia, but one of my personal thresholds is I would really prefer, if not in an emergency situation, to not provide consistent incontinence care for my father. Now, that doesn't mean that I wouldn't if I had to, but I know in my heart that ideally I would want support from someone else. But that doesn't change that my father may one day need that support. So I would need to know as his daughter, what safety nets, so what support can we afford? What support is available? What different things may be part of that? And so developing those safety nets and understanding what I call those thresholds can be really important. And it is frequently helpful if we think about those in a proactive instead of a reactive way. It is never too late to start pulling those solutions together. But what I do find is Our brain works best, we work best when we're not drowning, when we're not in a crisis. So having these conversations as much as possible while we're able to think outside of just emotionally can be really important. And sort of having thoughts about a progressive diagnosis and those potential changes. Connections with family and friends is really important. And that's not only for a person as they're diagnosed, but also for those that love and support them. And so they may be similar in terms of those. So it might be a couple that the person and their spouse is hanging with, or their partner is being with. And it might be individuals or separate types of supports. It might be that the spouse partner is involved in a support group only for them, and that the person diagnosed is involved in a support group only for them. And so making sure that those connections can be maintained as much as possible, even if there's modifications. So even if it goes from, girls' weekend to afternoon coffee, but not giving up on certain concepts, but trying to make modifications as much as possible. Also getting involved. I can't tell you how many individuals that I've spoken to that are diagnosed that really do want to and do lean into finding purpose in this. Sometimes we cannot help what we're facing, but we can shift or find a different perspective, and sometimes the why and what we can do for others because of what we're facing. And so we have volunteers called Lewy Buddies, and we'll talk a little bit more about that later, that provide support to others who are on this journey. And the way I describe it is they can hold the flashlight for you. That doesn't mean that they have all the answers or even know or can tell you the next step in your journey. They can help light the way a little bit, and often finding ways to give back and to stay connected can be really important. And the last one I think is really key. Understand as much as possible. So get the education when you can, vetted education. Love when needed. I use this word, it's a little crass, but I think sometimes describing it is just as accurate as I can get, is sometimes this just sucks. It sucks to experience it, and it can suck to support it. And again, not making light of it, but it can just be tough. So I think in those times, grieving, really coming to terms with the shifts that are happening and really leaning into the love, not only in the self-compassion we can give ourselves and saying, this is new to me, I'm learning, I give myself grace. As much as we can give back to ourselves in terms of trying to figure all that out, it's really important. And so I think we have to say, even myself as a professional in this space, every single day I support families. It's the very first time my father has had dementia. And so I have to give myself a bit of grace in terms of that support, even though I have knowledge around dementia support, it is still a different perspective. And so it's often, giving ourselves the love and care that we would give to others as well. In terms of education, we have an amazing amount of information, and sometimes that can be very specifically molded for you through our website. So if you have follow-up questions, we'll talk a little bit about connecting with LBDA and some of the specifics there. But learning about the diagnostic process, what medications may or may not be helpful or supportive for symptom management, what symptoms are part of this so that you can help to report those things to your physician, other community resources. And we do have as an organization some limitations in how we can provide that information because, as a smaller organization covering nationally, I can't know the quality of a home care agency in Alaska, for example, but I can help describe what home care is and sort of point your feet in certain directions in terms of what may be out there. Current treatments or medications, we talked about that, understanding some of the shifts that a person may experience, as well as connecting with other individuals that have been there and are on that journey. We also have a tremendous amounts of publications, downloadable materials, care briefs. One of the ones I wanted to point out, and one that will be a resource that is shared after this, is our medical alert card. So this is a card that basically said, my person has Lewy, I have Lewy. Please take certain precautions when I'm in emergency care. And so it gives some very minor but extremely important guidance if a person is being supported by emergency medical, hospital providers, et cetera, especially if they're having harder moments, which often can be the case if there is a fall with a head injury or an exacerbation of certain symptoms such as hallucinations and delusions. We do have a host of support services that are available through our organization. Our helpline that I've mentioned a few times is here, and you will have that information as well in your resources. You can also reach out to support through the support email, which is just simple word support@lbda.org. We do have a list of support groups under the support tab on our website. Some of those are facilitated by professionals. Others are facilitated by familial volunteers that have had experience. We have online communities through Facebook. We have a Facebook page for care partners, a Facebook page for those diagnosed, and a dyad-based Facebook page, as well as a bereavement page as well. So why do people lean into support? And this is often sort of where we come in and where we can help people, as well as how the other mechanisms that are there, such as support groups, can help. You know, for me, I think it really boils down to those realistic expectations, supporting dynamics as they're surfacing, processing the absolute host of emotions that can surface, not only for, again, the individual as they're experiencing these changes and symptoms, but also for all of those that love and support them. It can help to provide social connections, reducing isolation, really looking at quality of life. And one of my favorite parts is to share resources, tips, and practical information, because often if you're in it all the time, it can be tough to get creative because your brain's sort of on hyperdrive. But having someone from the outside say, have you ever thought about, you know, we tried this. And sometimes those are really great things that can shift an entire day if put into place. We also have a new app that just rolled out called Lewy Compass, and we have some information on our website about this. And this is an application that can help families organize things like medication list, have access to different resources and connections as well. You can also contact us. Again, our best ways are through our Lewy line, which is our helpline, as well as the support email, which is support@lbda.org. And that is my last slide. So Melissa, I am ready for questions. I see a few in the Q&A. If you'd like to share those with me, I'll do my best to answer those.
Sure. So the first one is rocking in a standing position, shifting weight between legs due to lack of strength to hold a solid, firm standing position, a symptom?
Oh, that is
I know.
Very detailed question/symptom. And I am unable to give medical advice, meaning I cannot confirm or deny that it is not a symptom or should not be concerning. The motor symptoms are more broad than people give it credit. So for example, when we talk about the brief statement that was made, when people think Parkinsonianisms, they think tremors. So I'll have people all the time to say, oh, no, they don't have any issues with movement. They don't have tremors. I was like, well, how's all these other things? And so there can be some positioning issues. There can be some postural issues like we've talked about. So always, if there's any kind of symptom, especially that specific, make sure that you're taking notes. Again, is it a certain time of day that you're seeing this? Is it a certain side that they're leaning to? I don't know if you're currently consulting with or have had conversations with a physical occupational therapist. That may be a great way to have certain pieces of that analyzed on a deeper way, as well as supported, because there may be certain strength exercises on a certain side of the body or a certain thing that can be done in terms of helping with some of this postural issue. But I would definitely recommend making sure that you are reporting that to the neurologist, as well as keeping good notes about what that looks like for your person, with some specifics. Again, is it backwards, forwards, side to side? Is it only when they're sitting in certain chairs? Is it, I think you said standing. So is it standing on certain types of floor? So is this carpet versus linoleum, for example? Is it uneven sidewalks? Is it outside versus inside? So having some of those context clues can be really helpful. And then of course, the doctor will very frequently recommend consultation with either outpatient rehab or some of the in-home based therapy services through services like home health.
Thank you. Our next question, are retirement homes and assisted living facilities reluctant to admit patients with Lewy body dementia?
Yes, that's the very short answer. And a very hard answer. I'm not saying this is across the board. But I can tell you, I used to be a nursing home social worker myself. So I've been on the other side of the receiving end. And one of the difficulties with Lewy is that we've talked about some of the symptoms, and some of the symptoms that we've talked about can be a very high liability risk for receiving communities. So for example, if I said a person is an extreme fall risk and has altered perceptions that can lead to certain behavioral presentation, that's tough to bring in. It's tough to admit, because not only do you have to think about the needs of that person to make sure that you have the care in place that can provide care, but it's also thinking about the needs of all the other residents that were there. So there can be some hesitancy. So a couple things that I recommend in that is sometimes making sure that they understand more about Lewy. And part of what I sent to Melissa to share with you guys is something I designed I call it my facility pack. And the reason I call it that is because I've had a bunch of calls of my person's in a place or my person's going to a place, and I want to make sure they know about Lewy. Like what should I tell them? And so often making sure that they have clarified information, doing one's best to position a situation with as much stability as possible. So a person may have had concerns 6 months ago, but now with medication, they're in a much different place in terms of their symptom management. I have people that will go into certain situations and be like, here's their 8-year medical history, as opposed to what are their current needs and symptom management. And so in zero way, shape, or form am I saying to be manipulative or lie, but I think it's also important to understand that acceptance is that's their point of control. That is their open door. That is their yes and no. And once a person has been admitted, I'm not going to say stuck with them. That sounds a little terrible, but that's their responsibility in those moments. And so making sure that there is open communication. If you have a facility that is blatantly refusing to accept someone because of a diagnosis, sometimes trying to figure out the why can be important. They may have just had a really terrible situation that happened with a prior individual, or it may be a certain symptom that your loved one isn't even experiencing at all. And so sometimes trying to dig in a little bit more there can be helpful. But unfortunately, yes, just like other conditions such as having a catheter, having an amputation, there's being a certain age, there are other factors that can play into if a person is appropriate for a certain setting or would be accepted for a certain setting.
So Brandi, and I'm going to add on to that just a little bit. I do encourage people,
Please.
if someone has a Lewy body dementia diagnosis, because we know there can be behaviors involved, that you're going to have better luck moving them into an exclusive memory care, because that staff and that community has more training with dementia and behaviors versus a CCRC or an assisted living that also has a memory care. So just kind of keep that in mind when you're looking.
We've seen that as well. I mean, I think there's exceptions all over the place to some of those things, but I would say in general, 100% yes, in terms of having that specialization and that understanding. You know, if they're built for memory care, they're built for memory care. And often they would be more likely to have experienced Lewy in the past and have more experience in how to provide that care.
Great. Our next question, should we tell the patient that we think they have dementia?
Ooh, these are great questions and a little loaded. This dementia is unique. Often there is such a different level of awareness within this dementia than with other dementias at times, especially later on. In many, many situations, the person knows something is different. And in many situations, as I've supported people with this dementia, they have said that in their circumstance, in their situation, it was a blessing to know, because knowing helped them understand the why. Now, on the flip side of that coin, are there situations where it could be a problem? Sure. You know, could it be a tough conversation? Yes. Could there be a specific person in that family that should be the mouthpiece in that conversation? Yes. Or should it be a time of day when that's shared? Yes. Or should there be a doctor maybe involved? Yes. So there's a lot of movable parts to that where I am definitely not going to say 100% of cases in either way is an appropriate response. But I can tell you I have supported now hundreds of individuals that are themselves diagnosed. And generally, the experience has been they were grateful to know that there was some reason that they felt different. And in certain situations, I know one of our dear volunteers calls it Lewy, like makes it a third party, and then has something to get frustrated with, has a thing to be angry with. I had a gentleman this week say, oh, it's just Uncle Louie paying a visit. So to him, like it empowers him to understand these other parts of him that do not make sense. And so I think in many situations, it's important to have those hard conversations. I think we also need to know that some words are pretty triggering to individuals. So I think a lot about the word alcoholism. So if I were to say that person is an alcoholic, almost everyone on this call would have a mind's eye view of what they see when they hear that word. That person looks like this. That person acts like this. That person has this kind of support. This person makes this kind of money. We have a person in our head. Sometimes when you say dementia, that word is understood in a certain way. So if a person says, oh, I think you have dementia, but they think about their grandmother that had Alzheimer's, and because theirs doesn't look or feel or act like grandmother's, sometimes it's the word itself. And so sometimes what I do is I take a step back and say, what's really important about that word that they know? So I love Dr. Armstrong uses a simple definition of changes to memory and thinking. And you've heard me say that a few times in this presentation. To me, that's a whole different way. Person, it seems like you're having changes to your memory or your thinking. And I'm seeing it in these ways. Sometimes that's different than just saying label. And so it's going to be sort of the responsibility of the family to understand, you know, that person much better than I would ever, Melissa would ever. So giving generalized advice of yes or no in all situations really isn't appropriate. But I think it's just important to say, you know, with my person, how would we make this most successful? What could and would they understand? What would be helpful? And then do you have supports for them after the fact as well? So is there other individuals they can talk to that have the diagnosis if that's appropriate, just so that they have that shared understanding? I hope that's helpful.
Thank you. Our next question, how does a person carry the medical support card?
Oh, great question. People do it different ways. I have some people that have other documents that they keep it with. So they have advanced directives, for example, they have that in a folder on the top of the fridge. So they have a copy at least of the card in that. I do have some people with a good old-fashioned wallet that keep it in their wallet. So it is a small card, and we do have smaller cards that we can mail as part of our mailed publications, and you can always reach out to support and we can help to connect those dots too. I did connect a link with Melissa that she'll share with you guys of the card that's sort of a larger printout, a little easier to fill out. I say keep it with your important documents. Some people keep it in the card that would most likely go to the hospital. I think that's a good rule in general, as well as your advanced directives and other key information like medication list, glove compartment box, sealed, take it with you. So it really just needs to be where it would be most useful, where it would be easy to access. You know, I've had a couple of people say, oh, I put it in my safe deposit box. No, probably not the best place. You know, good in sense of having a copy, bad in sense of not. I also think it's great to make a copy and anyone that could need to dash and run for that person. So for example, and I keep using myself or my father. So I would want a copy of something similar to that. So if I got a call now that I needed to be at hospital bedside, that I have things in the ready. And that would also include med list and other things too. But keeping that card where it's easy to show is really most appropriate. Here
in Fairfax County, we have a thing called File a Life. It's a magnet on our fridge. You can put it right behind that. That's always helpful. And if anyone doesn't have one of those, any of the fire departments have them and will gladly give them to you. But it's a magnet with a list front to back of all of your medical stuff, your medication, and anything that someone needs to know. The paramedics can just grab it off your refrigerator.
Beautiful. We also have yellow dot here in Georgia where I am. So some states will have other programs as well. So just knowing that all of this is sort of grab and go. So we'll just want to always make sure that it's up to date and that it is with that critical information and just really easy to access.
Thank you. So our next question, our doctor said he thinks this might be PDD. Does PDD progress like Lewy? Is there a difference?
I would say generally, there's some discussion in this, but PDD, meaning Parkinson's surface first and then the dementia and memory changes thinking happen after, sometimes will present differently because there can be different presentation of motor symptoms already. And so there may be some shifts and changes because a person is in a different place physically. Typically, treatments are very similar in terms of not only techniques that are supportive, but medications that can be helpful in terms of symptom management. So from that angle, it can be extremely similar, and often what we have seen is very similar advice in terms of how that's supported.
Thank you. The next question, how do we find a good psychologist if there might be depression involved?
Oh, I wish this was the easy answer. So word of mouth is my favorite. Asking facilitators like Melissa, if you've got people in your area, seeing who else people have liked and used. Mental health access sometimes is limited by different insurance networks. So my first advice is typically see who your insurance covers and then almost work backwards. Often physicians have a list of providers that they use, that they trust in certain things. And I think it's also important to know how you intend to use that person, because sometimes we'll use a word like psychologist, but we mean mental health therapist, or we say psychiatrist, but we mean counselor. And it doesn't mean that those words mean the same at all. It's just, we know what we need and we use a word, but it's not the right word for what we're wanting. So often in those kinds of situations, I try to say, describe the care you're wanting as opposed to the label of the professional. Because, for example, there are social workers, LCSWs, licensed clinical social workers here in Georgia. Other states, they could have different acronyms, but that are also therapists that provide therapy. And so there's different professionals that provide therapy in terms of talk therapy. There's also different positioning. Sometimes when people say support, they're not aware that there's informal supports, for lack of a better term, like other care partners they can connect to. So they're really just wanting someone to talk to, but they're not necessarily looking for that therapeutic relationship within a mental health therapy setting. And so, and then there's other tools like Psychology Today that has some filters that you can use to find the therapist in your area. But I really always say, if you want your insurance to pay for it, start there. And then get the list and then talk to your physicians next. And then other providers like Melissa here, anyone local that would know the lay of the land. Some families have also benefited from contacting an aging life care manager or a privately hired advocate to help with some of these connections of people that they trust in those scenarios.
Thank you. Our next question, do balance issues occur with Alzheimer's as well? Also, if there are memory and balance issues, but no hallucinations, depression, or anxiety, can this still be Lewy body?
I will not even play and pretend like I'm a neurologist. Okay. The answer is I cannot be clear on that. Are there symptoms that are found within other dementias? Yes. Part of when we talked about diagnosis, it's just so important to talk about the how. Because are there other physical conditions causing other things that you're seeing? So vertigo, inner ear related things, blood pressure related things causing balance, thyroid or inner working things, underlying infections. There's a host of things that could be causing what we see. And the example I always give is if I said I have a stomach ache could be acid reflux to stomach cancer and everything in between. So as you're talking to your doctor, it's important to say, and that's why I always sort of describe the Lewy symptoms, and please take a look at the symptom checklist that I showed. It'll be shared. those buckets of symptoms. So what are you looking at in terms of that? We also have some great criteria on our website about diagnosis, sort of the diagnostic process. So there may be other testing that they can look at. But again, tracking some of those changes in your person and then thinking that it could be other things as well. A lot of people will just have blinders on. It has to be this. There's no way it's something else. And then to make matters a little complex, it can be mixed in terms of dementia. So it could be Alzheimer's and. One of the hardest family cases that I've supported here was a mixed dementia of frontal temporal dementia and Lewy body dementia. And both of those dementias have very active behavioral presentations, very uncomfortable feelings that the person can have, some impulsivity, other things. And so it's important to know that it can be a yes and, not just an or situation. And so it's important as your doctor is trying to help you find the why that you're providing as much information as possible about what you're seeing and the changes.
Thank you. Our next question. My husband will stand and often right in front of what I am watching and seems oblivious, like his common sense is gone. Lately, he's asking such odd things. Today, he asked if girls need to pull down their pants to go to the bathroom. Like regression or confusion, are such odd actions part of LBD?
Can be. It very much can be. And part of that is just trying to figure out the world around them. We have to think that with Lewy and other dementias that often these brain changes, whether it be plaques and tangles related to Alzheimer's, whether it be Lewy bodies related to Lewy body dementia, often these changes in their brain are killing their brain cells. And so if we think about the brain as this like super highway, I think a lot about here in Atlanta, we have something called Spaghetti Junction, which just looks like a road nightmare of spaghetti noodles. That's why it's called what it is. And if you think about the way you normally get through life and imagine that your brain is constantly having to detour. So certain pathways of understanding of certain things aren't the same anymore. And so a place where they would have gone to get sometimes what seems like basic information or information that was definitely once familiar to them before, that path may be broken or damaged. And so they're just struggling to find this truth that their brain is trying to find. And so sometimes as well, a person may be just shifts in their awareness or their alertness. So, and if you combine that with changes to their vision and changes to their memory and thinking, sometimes there are these moments of zoning out or moments where they're needing more direction or support. So that can very much be a part of this dementia and with other dementias. And so, sometimes I think we have to, when we see them struggle with something, we have to sort of take a step back and breathe and say, okay, for them, what's the answer that might be satisfying to what they're needing to know? I always try to boil it down to, we all want to feel loved and safe and understood and heard. And if you get in those moments and you're like, oh my God, take a step back and say, what would I need to feel loved, safe, understood, et cetera, because they're struggling. And I know you're struggling to take care. And I never want to dampen the feelings that a care partner is feeling because they are so valid and they are so real. But I think in those moments we have to go like, okay, Louie's acting up, obviously. Hey, Bob, come here. Let's go in here. Let me help you to your chair, kind of thing. Move yourself. Sometimes, I have a caregiver that said, so-and-so, they keep spilling my tea and it's red tea and it's all over the carpet. And I was like, move the tea, and I'm not trying to make light of it, but sometimes we have to make shifts in what we're doing, how we're handling things because of shifts that they're experiencing too. And although extremely frustrating, and again, I want to validate your experience as a care partner and your frustrations as a care partner, because those are very real feelings. But sometimes you have to go, okay, we want this to happen. This isn't happening in this way. How can things be adjusted or modified to continue to meet that need?
Thank you. Our next question. Everything I find online says average lifespan is 4 to 8 years after diagnosis. But is there any info on a percentage of people who live more than the 8 years?
I do not have a percentage. I can tell you what we see as an organization is 2 to 20 years. The bulk of who I support would be probably in that 3 to 4 years to 12-year range. Now, there's a ton of things that affect what they call prognosis or lifespan. And sometimes that's other conditions. So, for example, I had a son that called, and dad was already in his 80s. He also had COPD, CHF, so breathing condition, heart condition, end-stage renal disease, and diabetes. And he said, so I read there's this 6 to 8 years thing. And I'm like, there can be complications because of other things. We talked earlier about car accidents and falls with head injury. Those can make things take a hard left, where the prognosis is sort of stable or the development or the progression is stable. And then all of a sudden things are very different. And so, yes, research as published, we're looking at that 6 to 8 years, I would say on average that is seen. But I can tell you there's quite a few in our Lewy Body Living with Lewy support group that would beg to differ that theirs is different, and that have lived 5, 6, 7, 8 years with this and are still incredibly engaged, volunteering, doing other things. And so it really is person specific, and anything involving prognosis and shifts, we again always pump back to your physician, especially if you're noticing changes. And then really be proactive in some of those safety related concerns to try to reduce risk.
Thank you. So the last question, my husband has been diagnosed with Lewy body dementia for a while now, but this week the neurologist stated that he thinks he has logopenic progressive aphasia. Can he have both? He has the symptoms of LBD, but he has extreme issues with his speech and understanding anything you say to him.
If you can't see my face, that's the first time I've ever heard that term. So I'm not going to claim that I've heard aphasia for sure. Yeah. I have never heard that specific type. I will give a very brief answer to say there are many things that are ands, not ors. And so I think it's really important to ask the physician, is this a replacement of, or is this an addition to? Issues with speech, giving and receiving, different types of abilities. Again, all of these symptoms look so different depending on the person. Can definitely be a part of, I would say, what would be under the umbrella of changes as a result of Lewy body dementia. But is it a separate condition that is caused by other changes, or is it a certain condition that's diagnosable because of the symptoms? I think is it an and or an or question definitely needs to be redirected to the physician. But I do know that those with Lewy can experience aphasia. It's just a matter of clarifying with the doctor and just seeing if they are clarifying the prior diagnosis or adding to.
Thank you. And so I just want to remind everybody, she cannot share the slides, but she did share a bunch of resources with me. I do have an email set up to go out to you after the presentation that you'll get those. I'm also working with our marketing person, and we're going to make sure that we can get those in a blog for you as well. And the recording of this will be provided within the next week on our website under webinars. And also a reminder, we do have a Lewy body dementia support group on the 4th Tuesday of every month from 2 to 3:30 p.m. So feel free to sign up for that. And then we have a special exciting event, March 16th. We're doing another Spark event with the Providence Assisted Living and the Landing Assisted Living at 6:30 p.m. So you can look on our event calendar and sign up for that. The Spark event is about Robin Williams having Lewy body and doing a Q&A afterwards. So we'll be happy to have you come join us for that. And thank you again, Brandi, for your time.
Thank you guys for having me. Take care.